You did mention some other drugs, all right? Before we go to the really expensive stuff, and some of this is not cheap. Zetia is one, bile acid sequestrants. Where do you use these? Are they effective? Do they really work?
Sure. So ezetimibe blocks absorption of cholesterol in the small intestine. It is not extraordinarily effective in monotherapy. You get 14%, 13%, maybe 15% LDL reduction. Tends to work great with statins. I kind of refer to it as hamburger helper for statins because it does get a little sort of a more robust response with statins. But there are times in which people have been statin intolerant with three different drugs, and the letter comes back, has the patient been tried on Zetia? This patient is 80 milligrams per deciliter away, and they would require a 60% reduction, and they want to know, have they been on Zetia? And you write them a letter that says there is no force of man that could ever make this guy's cholesterol come down.
But I want to refocus you for a minute.
Just before, does Zetia work?
But I'm not talking about the letter to the insurance company.
No, does Zetia work?
Does Zetia work?
Zetia does work in certain cases where you're not that far away from your goal. Okay. And you have someone with an LDL of 100 and you want them to be 70, you can add Zetia.
And what about the side effect profile of all these drugs, the bile acids and the Zetia?
So Zetia does have some first pass effect on the liver. There have been LFT abnormalities and myalgias, but not nearly as much as statins. The bile acid sequestrants are the earliest drugs that we had. Cholestyramine was the first. It was, it's largely constipating. Binds to other drugs, particularly thyroid hormone. And if you give it to certain older patients, you become on their very unfavored list because you've constipated them. There's a newer version of it that's a little less constipating, doesn't bind to other medicines, but that too, we get a prior authorization request.
Okay, so.
And it costs a fortune.
Yeah. And it costs a fortune. Okay. But here again, what I'm hearing is, these are second line drugs.
Right.
And they work with maximally tolerated doses of statins.
Right.
And if you're going to be a significant distance away from your goal, adding these drugs is probably not going to get you there.
Correct.
Right. So then you started jumping on this guy. You feel even jumped on?
Not really.
Because you're just equanimous here. Oh my gosh. But again, do you understand what they're saying? That if somebody says, have you tried Zetia? Have you tried cholestyramine? It's not going to work in their view. Why even bother?
Yeah, I totally agree.
That's ridiculous. We were hoping you'd fight back.
No.
Yeah, I agree
Do you agree too?
Yeah, absolutely. Yeah, as monotherapy, they're not going to help a patient reach their goals.
We know
Or if you have a long way to go, they're not going to.
Or if you, even as
I was
dual
talking
therapy.
more about add-ons.
Yeah.
Okay, but even as add-ons, if you're saying, if you're 30% away or 40% away,
and they'll give you
this
maybe half.
isn't going to get it done.
Correct. Correct.
Okay.
And we've had letters insisting that we give them Zetia, not just give them, we have to show 3 months of therapy and what numbers you get.
Then you have to wonder who's reviewing their PAs. Because if you're really clinically evaluating the prior authorization request, you're going to realize that that request doesn't.
So we have one person in the office, just about all she does is the PAs, and she's good. We have an
I'm
80.
saying within the health plan.
Yeah.
Within the health plan, you have to wonder if the person who's reviewing the PA is actually going through the mathematics.
But this problem
reduction.
is ubiquitous, and so from a utilization management standpoint, I mean there are problems in every insurance payer except for the two of you.
Well.
And we just published there was an abstract at the ACC looking at the IMS formulary. The IMS quintile database, and showed that regardless of statin dose, so high intensity statin, use of ezetimibe, use of dual antiplatelet therapy, which is really tantamount to having vascular disease, there's no difference between approved and denied in PCSK9 inhibitors across the board with either one of them. So something is radically wrong in terms of how people are reviewing the PAs.